don't know. So you can imagine for the CEO.
Yeah.
So we'll start I think it's about 5 past. If you're on the phone, if you could just mute your phone. And can you hear me? Oh. Oh. So we have Dr. Hess today. It's part of our visiting professor series in conjunction with VGH and Women's College. And Dr. Hess is visiting us from, can you hear me? Is it not on? Is it? Maybe, yeah, I'm not allowed. Can you hear me? I can hear me. Yeah.
Paula, I can hear you fine.
Okay. Oh, we can hear you too. Okay. So Dr. Hess is visiting us from Harvard. He's heavily involved in obstetrical anesthesia, and without delaying too much time with an introduction, we'll get the talk started. There'll be time after if anyone has questions, but I'm sure you'll welcome questions throughout if needs be. All right, and we'll start.
Thank you very much, and I appreciate being invited out here to speak. I wish it weren't raining as much because I would have loved to see a little bit more of your city. I'm going to be talking today about Clinician's Guide to Coagulation in Pregnancy, and there are several things about coagulation in pregnancy that are different, and so therefore I think it's important to discuss them and how they impact our patient's bleeding so that we can treat the patient more appropriately. I have no conflicts of interest to declare. We will have to go through the mechanisms of coagulation and identify changes in coagulation in pregnancy, but I'm going to be really focusing on 3 patients that I took care of personally and how their personal medical history or disorder impacted our care and how we need to change things. Why talk about hemorrhage? Hemorrhage, of course, is one of the leading causes of maternal mortality worldwide. About 150,000 women die every year bleeding to death in childbirth. That's a lot. It's about 1 out of every 1,000 live births in the world. It is a bigger problem in the third world, developing nations, than it is in the developed world, where in the developing nations it's the #1 cause of death, with almost 3 in 10 women dying in childbirth. 3 in 10 women who die due to hemorrhage in childbirth. That drops in rank in the developed nations down to 3rd or even 4th or 5th, depending on which country. So there have been a lot of advances that we have done in order to improve the survival of women who bleed in the developed world, but there's still a lot that can be done. One thing we know is that the incidence of postpartum hemorrhage is increasing in both the United States and Canada, and most of that increase is due to the increase in uterine atony. Why uterine atony is on the rise in our countries is unknown. It's several theories. One is that the increased use of oxytocin for induction of labor and increasing the speed of labor. Others include the increasing age of our population and increasing medical comorbidities, but it has increased in much of the developed world. In terms of hemorrhage, this data comes from California, and what they do in California, in addition to just collecting data about survivability in pregnancy, is they go into the charts with a committee that reviews the care provided to each patient and tries to determine whether that care was appropriate, and if the woman died, whether that care, if better care had been provided, they could have had a good to strong chance of altering outcome. And what they found was that consistently, year over year, obstetric hemorrhage ranks as the #1 source of maternal death, that if appropriate therapy had been applied at the appropriate time, there would have been a good to strong chance of that woman surviving instead of dying. So this is something that we can do better at. Even as we are improving, we can do better. There are lots of types of coagulation disorders that people have. Some of them are congenital, I'm not going to be talking about congenital disorders. There is a lot written about them. They're easy to research. There are also acquired coagulopathies, and among the acquired coagulopathies, the most common is iatrogenic, when we put people on heparin or low molecular weight heparin or other medications in order to induce a mild coagulation disorder so that people don't have pulmonary embolism. Again, this is something that has been written by European American regional anesthesia societies, lots of data on that. I'm not going to be reviewing those. Those are well written, and I believe that you all, being experts, review that all the time. What I will be doing, as I said, is going through several cases that allow us to review different types of coagulation disorders. My first is a 32-year-old lady who was twin gestation near term. She was Sri Lankan by history and had an amazing amount of vitiligo, so her skin actually looked like it was a leopard pattern. It was pretty amazing, and that actually comes into play in a moment. No other medical history. She did complain about fatigue, but it had been in the 80s. Sorry, that's Fahrenheit. It had been about 28, 30 degrees Celsius, and she had some new onset edema, and that new onset edema was what caused her to come into what caused her to come into the obstetrician's office. And when she came into the obstetrician's office, they put the fetal heart rate monitor on, and the fetal heart rate monitor was terrible. And they said, "Oh my God, we need to get you into the emergency cesarean delivery." So she came to us, and by report from that office, they said the pregnancy-induced hypertension evaluation was negative, which in hindsight meant they put the blood pressure cuff on and it wasn't elevated. So being urgent, I personally put in the IV, went through the history, put the spinal in atraumatically, and as we took her clothing off in the operating room, the first thing that became clear was she had bright yellow discoloration in all of her skin folds. Her sclera were yellow. Her urine was bright orange fluorescent. We had a delivery of the 2 neonates, and then she had significant uterinatony and diffuse bleeding. Because of that diffuse bleeding and the yellow discoloration, I sent labs, and what you can see in the labs is that she had a significant acidosis, and that acidosis was associated with significant change in her bilirubin, which of course gave her her yellow discoloration. Her AST, ALT were slightly elevated, but in a setting of an INR of 3.0, that basically means her liver was no longer functioning. She was no longer producing the coagulation disorder. She had fulminant liver failure. This is called acute fatty liver pregnancy. And in addition to liver dysfunction, she had hepatorenal syndrome. So she was very sick at this moment. Over the next 12 hours, she received over 100 units of transfusions in order to stop her bleeding. So what we're going to be talking about first is acquired coagulopathy. In this case was a failure of production. Gives us a chance to review the components of the coagulation system, which include all the things we learned in medical school, proteins and platelets, but also include the endothelial cells, which, as it turns out, are not passive conduits, but active participants in the coagulation system, vascular smooth muscle, and the immune system. And one thing I want to get across very importantly is that the immune system and the coagulation system are actually the same system. They're both part of the host defense system. Everything that affects the coagulation system also affects the immune system and vice versa. They are the same system. They're there to protect us from invading bacteria. Okay, who studied this in school? Who remembered it a week after the test? Who understood it? No one. And part of the reason is because it really doesn't make sense, right? And it doesn't make sense because this was actually developed by chemists about 120 years ago. And what do chemists do? Chemists look for an equation. A plus B goes to C. And so when they went to look for a coagulation cascade, they found A plus B goes to C, because that's what they were looking for. So this is a human construct, which actually doesn't make any sense. And part of that doesn't make any sense is right in the pattern. What's the difference between a damaged surface and a trauma? I never understood that. Or if you look on the left side over here, what you see is the partial thromboplastin time, right? The proteins of the coagulation system calculating the intrinsic pathway give you the partial thromboplastin time. And on the right, you have the prothrombin time, where you have to have the extrinsic pathway. And extrinsic actually means that you add something to the test tube in order to run the test. And what that something is tissue factor. And tissue factor, the major component, is thromboplastin. So how is it that I send one tube to the lab and all the thromboplastin knows to go to the machine on the left, and none of the thromboplastin goes to the machine on the right? The tube I send to the lab is citrated. And the job of citrate is to bind calcium. And binding calcium is sufficient to block coagulation. So if binding calcium is sufficient to block coagulation, where is calcium on this pathway? Right, so there are a number of other things on here that mean that this is not actually, it's a human construct. It doesn't explain coagulation. We have to replace it with something that seems a little bit more reasonable and helps us understand how women who are pregnant bleed and why they bleed in different patterns. So the initial phase of coagulation is always centered around tissue factor binding factor 7A. Right? So tissue factor and factor 7A will activate a small amount of factor 10. That small amount of factor 10 produces thrombin, and thrombin is the alarm bell of our coagulation system. And you can actually measure a thrombin wave. When that small amount of tissue factor, factor 7A bind, they create a thrombin wave that flows throughout our entire bloodstream. You can measure it. If it starts up here, you can measure it in your toe, which means our entire body would clot if it were only a coagulation cascade, but that's not what happens. What happens is this thrombin goes over and with calcium binds to the platelet, and that activates the platelet. And the activated platelet is the augmentation, amplification phase of clot formation. Without the platelet doing this, nothing else would happen. The platelet casts out a bunch of chemicals, about 100 different chemicals, which are part of the coagulation system, and it creates an entire zone around the platelet that not only creates coagulation, but also is a chemotactic calling white cells into the area. Then you enter the propagation phase, and part of the propagation phase is the hemophilia factors, factor 9 and 8, that bind factor 11 on the surface of the platelet again with calcium. That creates a prothrombinase complex, which creates massive amounts of thrombin, massive towers of thrombin on the surface of the platelet, which then create our fibrin network that connects all these platelets together. Without that process right here, without the activated platelet, without the thrombin towers on the activated platelet, you just don't have good clot formation. So we need to have functional platelets in order to create clot. This is tissue factor. And when I was in medical school, I thought tissue factor was just ground up tissue. That's whatever it is. What it actually is a very potent transmembrane protein that is part of the interleukin interferon family of genes. This is a very potent chemical. It's not just a mushed up tissue, and it has both procoagulant and inflammatory response. And when you overactivate thromboplastin, it will create both DIC and it can create an inflammatory response, much like sepsis. It activates platelets, but it's also found on the endothelial tissues and leukocytes. So it's part of this entire host defense system and creates both an inflammatory and procoagulant system. Now, I said platelets are a functional and important process, so I just want to identify some binding sites on the activated platelet. What you can see here is an electron microscopy of an activated platelet. Oh, come on, no, it's chewing gum. And what do we know about chewing gum? Is if you go into a kid's restaurant, it's found on all the tables on the underside, right? It's very sticky. And if you have a ton of chewing gum, what you can do is cover up an entire wall. And if there were a hole in this wall, you wouldn't see it. And nature understands that. And so nature's chewing gum is part of that activated platelet. And so it sticks to everything and grabs everything. And what it does is it grabs red cells and in order to help form a clot, and it grabs bacteria that are in the area, and it sends out these chemotactic factors that call white cells in, and the white cells come and kill the bacteria. It's a great plan. There are some changes that occur in pregnancy. Major changes include an increase in von Willebrand's factor that helps all these proteins bind, especially the hemophilia proteins, bind to the surface of the platelet to make this process more effective. You also have a dramatic increase in fibrinogen, and these changes in pregnancy then result in shortening of prothrombin and partial thromboplastin time, but a doubling of the normal fibrinogen concentration in the bloodstream. And that is an important marker that we're going to talk about in shortly. Where does that fibrinogen come from? Well, it comes from the placenta. And what you can see here in the Nitterbuck's layer is fibrinoid deposit. Basically, a clot is nature's glue. And so the placenta sets down and it creates a fibrinogen thromboplastin motor that creates a huge blood clot without red cells, but a clot that sticks the placenta down to the myometrium. So we have a fibrinogen and tissue factor process going on right there. And when the placenta comes off, regardless if it's a vaginal delivery or a cesarean delivery, when the placenta separates from the myometrium, mom then takes in a huge amount of soluble tissue factor and factor 7A. Now we know those are the initiation phase of clot, which means as soon as the placenta comes off, mom is in active coagulation state, right? She's an active DIC. The second thing is, in addition to increase in clot formation, we have a reduction in fibrinolysis. Now, the natural inhibitor for fibrinolysis, or tissue TPA, is the plasminogen activator inhibitor, PI1. And PI1 floats through our endothelial cells and prevents clot, which is forming in inappropriate areas, from sticking around. So it helps lyse the clot that we have. And in pregnancy, what you have being produced again at the placenta is PI2. PI2 is an inhibitor of TPA, which prevents clot from breaking down. And this is the reason why we often see patients who come in with an abruption. That abruption will stick around, and they can actually have a chronic abruption for a month or longer, right? So this abruption at the level of the placenta just won't break down because of the effects of PI2. And then people have this chronic abruption for a month. Otherwise, if that clot broke down, they would bleed again and again and again, and it would be a major problem. And that brings us to case number 2, who's a 37-year-old, 36 weeks gestation, and she had a chronic abruption for about a month. She had no bleeding over that month, and she was otherwise healthy with no medical issues and no allergies. She did have stable labs, and her labs there, you can see hematocrit of 32%, platelets were 260, fibrinogen was 6 grams per liter. So great, and the obstetrician was actually debating whether she should cancel the type and cross. That's how, which we keep on these patients, that's how stable she had been. They decided to induce her because of the chronic abruption, so they started oxytocin, and when she started having some evidence of labor, they asked for an epidural. So we placed the epidural, she got comfortable, and the attending obstetrician went into the room to do an assisted rupture of membrane. She ruptured the membrane, amniotic fluid came out. It was immediately followed by a significant amount of vaginal bleeding. The patient commented she felt very bad. She sat up, fell backwards unconscious, and started seizing. Stat emergency cesarean delivery was called. She was taken to the operating room in under a minute from that call. There was an uneventful rapid sequence induction. Endotracheal tube was placed. Delivery of the neonate was 4 minutes after we entered the operating room, which is probably what saved her life. Patient, when I entered the room, I was actually next door when this got called, appeared mottled and cyanotic, almost purple color to her skin as she was seizing. When we intubated her, the end tidal CO2 ranged between 5 and 10. She had a significant bradycardia and hypotension, 2 millimeter ST elevations inferiorly. Based on that, I was concerned that something in addition to abruption was going on and bleeding. So I put a transesophageal echo in, and what you can see here on this echo, just for orientation, this is the aorta and this is the pulmonary artery. And normally the pulmonary artery runs about 70% the size of the aorta, and you can see it's significantly dilated, suggestive of pulmonary hypertension. Here for orientation, you can see the left atrium and the right atrium. This is the right ventricle. Left ventricle is over here hidden. You can see that there's a viscous streaming fluid going through the right atrium into the right ventricle. And you can see that that exists only on the right side of the heart and not on the left side of the heart. So this is occluding passage through the lungs. And equally importantly, when the ventricle contracted, you can see that the intraatrial septum is bowing from the right ventricle into the left ventricle. So this means that there's a higher pressure in the right ventricle than the left. This, of course, is an amniotic fluid embolism. The value of the TE in this case was I could see the exact moment that the heart stopped beating, and we started chest compressions immediately. Gave 2 cycles of epinephrine. She did have a perfusing rhythm and then a pulse within a few minutes, and then we activated the massive transfusion protocol. Amniotic fluid embolism occurs in about 1 in 8,000 cases. It is a leading cause of mortality in pregnancy. One of the causes of mortality in pregnancy, studied by a review by Morgan in 1979, which is still the largest, had 86% mortality. And interestingly, 25% of that mortality occurred in the first hour. So those were patients that immediate pulmonary embolic event caused enough cardiovascular derangement that they died, which almost happened to this patient. But the interesting part of that is that 75% of the patients who died after the first hour, and they die from hemorrhage. Clark found that, again, 85% of patients had either death or significant neurologic dysfunction, and that's probably all the amniotic fluid streaming throughout your body, causing injury in end organs. Signs of an amniotic fluid embolism include restlessness, numbness, seizure, shortness of breath, chest pain, etc. There are risk factors in the literature, but they're really irrelevant because you can't predict it and you can't prevent it. It's something that happens very rarely and unexpectedly. The interesting ones here are the 2 at the very bottom, male birth and meconium. And the reason they're interesting is that they are suggested that this is not a purely embolic phenomena. This is an anaphylactoid reaction, a reaction to antigens that cause mom to become immune hyperactivity. And that immune hyperactivity then leads to an overstimulation of the coagulation system, or consumptive coagulation we call DIC. That gives us a chance to talk a little bit about consumptive coagulopathy and DIC. Of course, the requirement for DIC is not just having clot formation but it requires an overstimulation of the immune system. This is why you often see DIC in the setting of sepsis or other immune states. What happens is you have solubilized tissue factor often floating on small cellular debris throughout the system, creating clot formation in the microvasculature. That clot formation then causes significant end organ injury. That end organ injury perpetuates and causes more clot formation. Treatment, of course, of DIC is elimination of the cause, because if you don't eliminate the cause, you won't be able to get rid of the overstimulation of the immune system, which is inciting the defect. In pregnancy, DIC has been associated with a number of disorders. These include amniotic fluid embolism, as with this case, placental abruption, where the size of the abruption has been associated with the amount of DIC, and that, of course, makes sense because we know that that's where the tissue factor and factor 7A are coming from, which are inducing the consumption. It's also been associated with preeclampsia HELLP syndrome, IOFD, and maternal sepsis. Despite decades of research into DIC and sepsis, this is something that we in medicine have not altered. Sepsis remains one of the most common causes of maternal mortality throughout decades, and I would submit that if you take this list of maternal cause of death, it represents probably the majority of maternal cause of death in the developed world. So DIC is something that affects most women who die during pregnancy. That leads us to case number 3. Case number 3 is a 31-year-old female with a singleton vertex pregnancy near term. She had a transvaginal ultrasound that demonstrated a possible accreta. There was an elective cesarean delivery that was planned in order to prevent her from going into labor and coming in the middle of the night, because it'd be easier to take care of her in a organized fashion. In terms of preoperative preparation, knowing that she was at high risk for bleeding, we checked her type in we had a type in cross and checked her hematocrit, which was excellent. Placed 2 large bore IVs in our arterial line in preparation. She had was very thin, had an excellent airway, so we chose to start with epidural analgesia in case this turned out to be nothing. We could just finish the case. If we needed to, we could easily intubate her further on. There was uneventful delivery of the neonate, turned out to do fine, and the mother throughout the preoperative preparation consistently said she wanted to have more children. Unfortunately, her possible accreta was actually a full thickness increta, proving that ultrasounds lie. You can see here the placental components and the full thickness increta right here, taking out the entire wall all the way down to the serosa covering the uterus. The obstetrician in this case attempted to remove the placenta because of mom's wishes. That left a 5-centimeter defect that poured blood out, that caused mom's face in about a minute to turn pale white like a piece of paper. We started transfusions immediately, started phenylephrine infusion. That didn't suffice, so we started a norepinephrine infusion for her. EBL was about 3,500 in total at the end, but that all occurred in about a 5 to 10 minute period right after delivery of the placenta. That leads us to our final type of coagulation disorder, which is a dilutional coagulation. The incidence of postpartum hemorrhage overall ranges from about 3 to 5%. It's common to require 1 unit of blood. About 2% or 1 in 50 women do so. Needing more than that is decreasing, is very rare. However, that incidence is increasing, and specifically associated with placenta accreta, where the incidence, because of the high C-section rate, the incidence in both the United States and Canada is about 1 in 750 pregnancies. So this is a growing, increased problem. Cause of postpartum hemorrhage is both uterine and non-uterine, and the uterine causes are by far more common. 80% of the time, the postpartum hemorrhage is due to the uterus, and the most common cause of uterine bleeding is uterine atony, which I have already identified is increasing. However, I would submit that the non-uterine causes of postpartum hemorrhage are worse, not because they're worse innately, but because by the time people discover them, it's already far down the pathway, so there's been a significant amount of blood loss. This can be retroperitoneal hematoma, liver hemorrhage, liver capsular hematoma, etc. And so these bleeds are often not noticed. And the one thing that I always recommend is if a pregnant patient, postpartum especially, has unexpected hypotension, that the first thing on your mind should always be having a high index of suspicion for a non-uterine source of hemorrhage. There is an association between postpartum hemorrhage and the type of delivery, with vaginal delivery being least and an operative delivery, either vaginal or cesarean, having a higher risk of postpartum hemorrhage. There probably is a degree of selection bias here. You would never take a patient with a placenta previa and do a vaginal delivery, so there's going to be more likely to be more bleeding with a cesarean delivery, but there is an increased risk in those cases. This is the treatment of postpartum hemorrhage. I'll let you all memorize it and go. Now, we'll just kind of summarize it here. Number one, identify and correct the cause of hemorrhage, and that's the job of the obstetrician, surgeon, or interventional radiologist. Number two is resuscitate the patient, and that is the job of the anesthesiologist, and then everyone's job is to prevent further complications, including rebleeding and infection. So if our job is to look at methods of resuscitation, how do we do that? We can look at clinical and we can look at laboratory. Clinical would be things like blood pressure, estimated blood loss, whereas labs, of course, are things we're going to be sending out and getting answers back. Let's start with clinical. Obviously, the most accurate is a change in hematocrit over 24 hours, but if you have a sudden 3,500 cc blood loss in 5 or 10 minutes, you're not going to have time to be able to wait for that, so you need to treat it. It's really not clinically useful. How about an experienced clinician witnessing blood loss? Well, the fact is there are dozens of studies that demonstrate that we, especially the better trained of us, are worse at determining how much blood is sitting on the floor and in the laps. It's just not something you can do with your eye, and no one can train you to do that. Some people have tried to come up with different visual aids in order to improve the likelihood that you will be able to get a better estimate, visual guesstimate of blood loss. This is one such thing, which is a graduated drape. And so what they did was they marked off 500,000, 1,500. There are commercially available copies of this, mostly used for vaginal delivery. But you can see it's a lot easier to tell how much blood is in the drape on the right than the drape on the left. And in a simulated environment, the creators of this were able to demonstrate that people who used a non-calibrated drape were pretty inaccurate, and the more blood loss, the more inaccurate they were, exactly what we know from the literature. But those who used a calibrated drape on the right were actually very accurate in how much estimated blood loss they had in the simulated environment. And then they crossed over and took the people who had the calibrated drapes on the first one, and they remained pretty good. They could still think in their mind where that line was, and so came up with pretty good estimates of blood loss. And of course, the people who now had a calibrated drape learned. So this would be great. Unfortunately, when they went back and tested these same people 6 months later, the knowledge had been lost and they could no longer estimate. So it's something you have to have every single time, not just a one-time learning event. Others have used other types of visual estimates, and that includes using pictures to show you how much blood is in each of these laps. And this is 25, 50, 75, and 100. Right? So this comes out to 250 cc blood loss. That's a lot more than I thought it would be. So it actually helps if that's what you have. Now in the obstetric environment, we actually have one more thing, which is a neonatal scale. And probably the most accurate way that has been used to measure blood loss is gravimetric. So you take the neonatal scale and you can actually weigh the laps and dressings and get a very accurate measure of how much blood loss there is. And that's what we do routinely do for our hemorrhages. How about other clinical measures? This comes from the trauma literature, and it suggests that as you have increasing blood loss, you're going to have a increasing pulse rate, decreasing pulse pressure and blood pressure. And what I can assure you is in the obstetric population, this is completely useless. Much like the pediatric population, pregnant women compensate, especially if they have an epidural or spinal in place, they compensate until they don't and they fall off the cliff. And this is not something that you should rely on in the obstetric population. It will not help you. Well, if we can't use clinical measures, maybe we can use laboratory measures. And so This paper, 2011, by Deloitte, looked at what kind of laboratory measures are helpful during a hemorrhage. They had 456 major hemorrhages of greater than 1,500 cc blood loss, and they found that fibrinogen was the only factor that actually correlated with the degree of blood loss on multivariate analysis. Partial thromboplastin time and PT really didn't correlate as well as fibrinogen, and here you can see that they were able to keep up with hematocrit all the way up into 5 and 6 liter blood losses. So it wasn't a great measure. It helps you know when to give more red cells, but you're able to keep up with hematocrit if you have a good transfusion methodology. Well, what really correlated was fibrinogen. You can see that the lower the fibrinogen, the greater was associated with a greater degree of blood loss. So it's harder to keep up with fibrinogen, and partly that's because fibrinogen represents 85% of all the coagulation proteins, right? It is the one marker of coagulation proteins. This study by Charbit actually changed the game a little bit in that they had a significant number of hemorrhages, but what they did differently, they were at 3 centers in France, and what they did differently is at time 0, when someone said, I think we have an obstetric hemorrhage, and they said it in French, so it doesn't really, but when they said we have an obstetric hemorrhage, they drew vials and sent them to a lab elsewhere in the country. So that lab had no idea what the outcome of this hemorrhage was going to be. And then they went back and they correlated hemorrhages to either a postpartum hemorrhage or a severe hemorrhage. And the criteria for severe hemorrhage was a decrease in hemoglobin by 4 units of red cell transfusion, some intervention like hysterectomy or interventional radiology. None of the patients died in this study. So comparing patients who had severe hemorrhage versus those with a non-severe hemorrhage, what they found was that the time 0 fibrinogen was significantly lower in those patients who went on to have a severe hemorrhage. And in fact, none of the patients, or all the patients with a fibrinogen level below 2 grams per liter were in the severe category. And remember, fibrinogen is usually 4 or 5 in the pregnant population. What does this mean? This goes back to that schematic of the placenta. When the placenta peels off of the myometrium, it creates a hypercoagulable state, a consumptive coagulation. So when these patients had when they started their hemorrhage, they were already deep into a significant consumptive coagulation, deep into the DIC picture, when they were getting going. And so fibrinogen is a marker in these patients for obstetric hemorrhage being a severely coagulopathic state at the start of a hemorrhage compared to trauma. What we do believe, which will be very hard to test, is that obstetric hemorrhage requires significant teamwork, communication, organization, and protocols. Talking about protocols, we have to write these down and discuss them and to practice them. And we have to have some system. What we have here, and I don't mean for you to read them, but on the left is a call pager list with names and numbers and who to call. And whenever we have a major case like this, we have a clinical advisor who comes and sits with this phone list and is able to direct phone calls so that the clinicians don't have to do it. We take someone who doesn't directly care for the patient because you want the people caring for the patient to focus. And on the right, we have just our pathways for hemorrhage written down. And if we, my other slides didn't pop up. Let me just see one thing. Apologize. Saved. If we talk about protocols, we'd be remiss not to talk about the massive transfusion protocols. And of course, there was some evidence in the literature that a 1-to-1-to-1 whole blood ratio of transfusion might lead to better outcomes in battlefield or trauma cases. That, of course, was tested last year in this study, which is the proper trial, which looked at trauma in the emergency room. I'm sure you all have reviewed this at some point recently, but basically the resuscitation was randomized for these trauma patients to either a 1-to-1-to-1 ratio of platelets, FFP, and red cells, or a 1-to-1-to-2 ratio of red cells, so a red cell heavy concentrate. This was done immediately upon arrival of the trauma patient to the emergency room and continued until the hemorrhage was finished. And what the study found was that there was absolutely no difference in 24-hour or 30-day mortality, which were the primary outcomes for this study. There were some differences in coagulation disorders after the initial resuscitation effort. So the patients who were in the 1-to-1-to-2 group needed to have some additional factors given to them in order to catch up with the coagulation disorders that they continued to have, but there were no major outcome no differences for their primary outcomes. There's a question of how this directly applies to obstetric hemorrhage, because different than trauma, patients who come in for obstetric hemorrhage are in DIC at delivery. They're already consumptive coagulopathy as measured by that fibrinogen. Furthermore, different than trauma is there's usually one organ that we're dealing with, and it's just the uterus. And then there's a lack of predictive nature, as opposed to having somebody call in the ambulance saying, we have a trauma coming in. Oftentimes, we discover we're in obstetric hemorrhage when we're already halfway through it, and people finally wake up and say, ooh, this is bigger than I thought. So there are significant differences in terms of when we discover it, how we discover it, and what we do, and furthermore, whether the patient is already in a consumptive coagulation or not. The question of transfusion-related acute lung injury, of course, has been somewhat studied. There was a paper last year looking at it. It is fairly uncommon in the obstetric population, but still is always a potential. In addition to teamwork and communication, you have to have some form of simulation for obstetric trauma, and I think not just practicing trauma or bleeding for obstetric hemorrhage, but also practicing your systems. And I'll give you a good example from a hospital nearby mine. As I was talking with the nurses there, they said that they were practicing simulating obstetric hemorrhage, and one of these events, the runner who had to go to the blood bank went down to the blood bank, and the hallway was under construction. So they had to go all the way around the hospital. It took an extra 10-15 minutes, and no one knew about this construction, right? So in this simulation, they discovered that if they were going to have an obstetric hemorrhage, they had to do something different. And so had they done that in real time at 2 o'clock in the morning, it would have been a disaster. They discovered it through simulation. So sometimes you discover things in your system through simulation that help you prepare for a real-time patient event. We discussed the mechanisms of coagulation, including that tissue factor initiates the entire process, which in the obstetric population occurs really at the separation of the placenta, that the entire coagulation system requires the activated platelet surface in order to create a formed blood clot. We identified changes in coagulation in pregnancy and how that matters in the various forms of obstetric bleeding, and then discussed coagulation during obstetric hemorrhage, including causes of DIC and fibrinogen really being the best marker in obstetric hemorrhage. And I thank you very much for your attention.